Kohn, you're going to go first.
Recording in progress.
So Dr. Kohn came to the University of Minnesota by way of the University of Illinois at Chicago. So it's interesting you both came via Chicago, just different institutions. Is matched to go to a fellowship at Leahy Clinic next year in Massachusetts. And has had a productive career with us so far as a resident. And I'm not going to read through all your publications and all the things that you've done. I'll let you speak to yourself. And Dr. Leishman will follow. Dr. Leishman from Chicago as well, just from Loyola was his route. And he will be headed next year to minimally invasive surgery at... Yes. Similarly, could go through his list of publications, but I'll let you guys have this time because I think this is one of the most exciting things that we do for Grand Rounds.
All right. Okay, hopefully that's appropriately positioned. Good morning, everybody. For those of you who somehow don't know me, my name is Julia Kohn. I'm one of the graduating chiefs in my 7th year here in this program. The title of my talk is A Reason to Live. I've known the title of this talk since the beginning of my 2nd year of residency. During the pandemic, very early in the pandemic, Dr. Chipman, who's not here, began sending emails to the entire Department of Surgery, kind of about whatever was on his mind. And this one went out. Dr. Julia Kohn jokingly said this week she was going to the cafeteria to find a reason to live. She gave me permission to use this anecdote. In fact, she did not need a reason to live. And then he went on to talk about, food and the comfort and joy of cooking. Mackenzie White, recent graduate from last year, has often reminded me that the 8th floor cafeteria at the U is not where to go for that. So then what? So I thought I'd take you all on a tour of all of the birds that I've seen over the last 7 years in exhaustive detail and try to convince you all to come bird watching with me. I actually want to talk about art history. And that's why I haven't been telling anybody what my talk is about, because I knew you all were going to think I was going to talk about birds. So for context, this is a very brief, broad overview, mostly rooted in Western art history, because that's what I know the best. We see a lot of, publications in our literature, how art can make things better for us as trainees, as physicians, as, how art can make things better for our patients. But more broadly, I argue that art in itself has a fundamental role in the provision and care of medicine. Damien Hirst is a contemporary artist who, I'll talk about this work, Pharmacy, in a little while. He was interviewed at the time that this work was installed at the Tate Gallery in London. And he was asked, why a pharmacy? Why are you creating this installation artwork that is meant to mimic being in a pharmacy? And he said, well, people have confidence in medicine, but I had a confidence in art that comes from God knows where. And I noticed that people were believing in medicine in exactly the same way that I wanted them to believe in art, and they weren't doing it. And that's been my sort of guiding principle throughout this talk is, why do artists make art, and how can I convince you to believe in art the way that we believe in medicine? Over time, artists make art focusing on what's around them, what's urgent to them, what's most personal to them and to society. And there's sort of a guiding thread of know thyself throughout art history as a whole. Art can be used to communicate medical knowledge, can essentially provide a credential for the physician and for medical care. In itself, it is a means of healing, and in contemporary and postmodern art, it actually converses very intimately with medicine and with the things that we do and recognize. So first, to begin with, art communicates medical knowledge, and in fact, generates medical knowledge. As you go through, especially the rare book collections of art museums, you'll see old medical textbooks and engravings and illustrations such as this. This is called Wound Man. There's a couple of these, or there's many of these rather, and they are all characterized by, you know, many usually traumatic injuries, and someone who's still being portrayed as living, sometimes in front of physicians. This is the front page from a textbook of surgery from I want to say 1500s. Um, and an art historian who has recently studied these argues that they function both as a way to share medical knowledge. Here are the treatments that I can provide. Here are the treatments in this book, and also as sort of a repository for hope for the people who might see it. Not just here are the treatments, but there are treatments, and here are the things that we can help you with. These are a couple additional images from a surgical textbook. This Hans von Gersdorf is actually a surgeon rather than a trained artist. This on the what is that screen left is both a wound man and functions as an index for the book. So, okay, you have a sword to the ribs, go to page 35. You have a sword to the thigh, go to page 45. And then this drawing, which was actually a diagram of where to perform bloodletting, indicates that the artist had seen an actual dissection because as we recognize it, the heart and lungs are taking up most of the space in the thorax. The lungs are sort of over the heart, and that is not something that would have been identifiable necessarily without our dissection. Early medical texts mostly took this form, and this is a page out of Galen, who was active in the early 1st and 2nd centuries in Roman Greece. And then his work was propagated as sort of the premier medical textbook for the next 14 centuries. And all of it was handwritten. There were very minimal to no illustrations. This is a page from De Pulsibus, which is about the pulse and the circulatory system. But we have no diagrams. This was medical convention to have all of the medical textbooks sort of in this format. But then we reached Leonardo da Vinci. Oh, sorry. On Da Vinci. And you all know the Vitruvian Man. The Da Vinci is notable for his detailed anatomy, his detailed drawings, many of which were not published during his lifetime. And he performed anatomic dissection as a way to learn about the anatomy of the body to further his own artwork. And one art historian argues that he is seeing what others don't see because he's looking at it with an artist's eye rather than a physician's eye. He's not coming to it trying to prove the things that were quote unquote known from Galen. He's coming at it to see what's actually there. And so you can see in his drawings of anatomy techniques that we recognize today. In going through some of his work, I found direct comparisons to my own anatomy textbook that I've had for the last 10 years. Leonardo intended to write an anatomy textbook, didn't end up publishing it, but his drawings more or less originate a lot of the conventions that we see in modern anatomical diagrams. So here you have bones of the leg in multiple angles, the action of the joint, the bones of the foot. He shows the tibia and the fibula inserting onto the calcaneus here in this sort of exploded view. Again, this was something that he invented. Still a diagram that we're using today. And he also showed deeper portions of dissections by flapping up muscles or partially cutting away muscles so that you could see what lies underneath. And again, that is a convention that is familiar. Like I said, his anatomy textbook was never published. Andreas Vesalius, however, wrote the book that became the premier anatomy textbook for the next several centuries, De Humani Corporis Fabrica, which was published in 1543. Vesalius was a surgeon and was the dissector. His artist, who he worked closely with and supervised directly, is not known because at the time, as an artist is more of a craftsperson in some ways. The point was not the artist in himself or as an artist, but it's thought that this was the work of Jan Stevensson Kalkar. And his book is unusual to us, or in our eyes, because it's very decorative. These skeletons, the one on the left is leaning on a column with a memento mori, contemplating a skull and leaning on a column, were both commonly recognized styles or tropes for, remember you will die in sort of the religious context of the time. The background, this sort of pastoral setting, and the lifelikeness, the liveliness of these skeletons, although it looks unusual to us, would have been convention at the time, would have been recognized by his audience. Oh God, sorry, I keep getting this wrong. This is a series photoshopped together of his muscle man drawings. These engravings are some of the most famous from the anatomy book, and you can actually see, if you lay them all out next to each other, they're serial dissections going through the different layers of the anterior and posterior muscles. But the landscape behind this anatomic figure is continuous and was actually part of a larger whole as designed by the artist. Again, there are some memento mori features in here, such as the ruins that you can see behind the figures. Again, the convention at the time, remember that you will die. And anatomy books, through the function of the art and through the attention that the artist can draw to specific things that they want you to pay attention to, teaches a shared disciplinary gaze. The way that they encourage you to look at these things, and similarly how we look at things, how we look at dissections in sort of a shared language, is something that we can see in Vesalius and we can see today. Art also forms a credential for the physician and for medical care. In the 16th century, 17th century, surgeons had their own tools, they had their own instruments, and many of these, or at least the surviving examples, are highly decorative. So we have several examples of surgical scissors with elaborate handles with engraving. This is a tortoiseshell and silver box that was a pocket surgical kit. So if you were a surgeon making house calls and you needed to I&D something, you might pull this out. And all of these sort of provide a credential that you are a physician, that you are professional, successful, and able to spend money on your work. Likewise, amputation saws, which amputation being unfortunately common at the time, were highly decorative with engraving work, gilt work, fancily carved handles. And you might think, well, what's the point? But if you go to a surgeon and they have this hanging in their office, that might be more reassuring than going to somebody who says, sure, I can amputate your leg, and pulls out, the butcher knife that they used last night for dinner. This is a painting by Rembrandt van Rijn. It's probably one of his most famous paintings. It's titled The Anatomy Lesson of Dr. Nicholas Tulp from 1632. And in the 17th century, and especially in the Netherlands, we saw the advent of portraiture, and not purely for aesthetic impact, but to serve a function, conveys ideas about the person that's depicted. It can document events, and these are designed to be seen by the public, responded to by the public. So if you have a painting of yourself at a dissection or in a dissection that tells the public, I have this credential, I was there. At the time, cadaver dissection was more or less an annual event. The cadaver was obtained from a convicted criminal. And these were public events. This is more of an allegorical depiction of the dissection itself. But the convention became that the Surgeons Guild in Amsterdam commissioned a portrait every time one of these anatomy lessons or dissections was held. And so if you wanted to be included, you also had to chip in for the group portrait. So again, this is a credential. I was there, I was at this lesson, I'm successful enough to have myself painted into this painting. And that would have been, visible by other surgeons, visible by the public. Here are a couple of other examples of anatomy lessons. The Surgeons Guild in Amsterdam specifically has a long tradition of these. From the top is from 1603. The left is from 1670, and then the right is another Rembrandt from 1656. Unfortunately, this one was heavily damaged in a fire, so only a fragment remains. But just from a personal point of view, it's fascinating to see the way that he chooses to depict the body, the highly artistic approach to the cadaver. Again, portraiture could depict you, how you wanted to be seen as part of your role in society. Rembrandt was also commissioned for this engraving of Ephraim Bueno, who was a Jewish physician, in his, characteristic attire as a physician. Again, a portrait that was designed to act as a credential, emphasize that his role in society. And then skipping forward to the 1880s, John Singer Sargent was a prominent American portrait artist, and he was well known and well regarded, and so many society members commissioned him to paint their portraits. This is Dr. Posse at home. He was an obstetrician gynecologist, and he's in his comfy clothes, more or less, but the emphasis on red in the image calls the mind to the blood involved in his profession. The emphasis on the detail of his hands, acts as a credential for the delicacy and the care involved in his work. You also, again, you've got the fancy slippers, you've got the fancy dressing gown. Again, this is somebody who is successful enough to commission Sargent for a portrait and wants to show it. Switching gears a little bit, still in the 1800s, in America, art can be used to document major events and can be analyzed from our perspective for major events in the evolution of medicine. So I have a little timeline here. These three paintings I'll talk about next. The first surgery under ether occurred in 1846. In 1847, Semmelweis realized that washing your hands in between the cadaver lab and your childbirth patients helped prevent puerperal infections. In 1867, Dr. Lister began practicing antisepsis in his operating room. He lectured in 1876 in the United States. And then in 1882, the germ theory of disease began to be propagated. At the same time, two portraits of prominent surgeons in society were painted. And then also notably in 1899, a student of Dr. Halstead's published a paper suggesting that wearing surgical gloves prevented surgical site infections and hernia repairs. So this is the first operation under ether. The surgery itself was in 1846. And you see, this is the conventional operating theater of the time. So it's an event with many students watching. Everybody is in a black coat, which was the characteristic attire for a physician at the time. And you have a patient who is anesthetized with ether having surgery on his neck. And there is calm, deliberate, much more relaxed than we think of with earlier amputations, and let's do this surgery as quickly as possible because the patient doesn't have any pain relief. Thomas Eakins was another American portraitist, and this is called the Gross Clinic from 1875. The surgeon was Dr. Samuel Gross, although the painting itself is kind of gory. Again, you have students in the background. This is actually Thomas Eakins himself, painted himself into his portrait. And the patient on the table is undergoing a leg operation. There's blood. His mother is there, wincing and grimacing. And Dr. Gross has his scalpel in his hands. Everybody is still wearing sort of a black uniform. In 1889, which is just after Lister, after Lister spoke in the United States, after some of these ideas of sterility are beginning to make their way from Europe to the U.S., Thomas Eakins painted another portrait, the Agnew Clinic. And this Dr. Agnew is here still lecturing, still in front of medical students, but everybody in the surgical field is wearing white, which is our convention. And everybody here is professional. Nobody's mom is in the operating room. The patient is being anesthetized with ether and a cone and they're performing a mastectomy. So within a 12-year period, we see the shift from black coats, which hid the bloodstains, to white coats, which don't hide the bloodstains on purpose to demonstrate we have anesthesia, we're practicing sterility, and I'm not chopping your leg off as fast as I possibly can. I have the time and the skill to do this deliberately and carefully. I also find it notable, and I threw in that reference to Halstead's student in the glove study, because neither of these men is wearing gloves of any kind, and they have blood on their fingers, which again, something that we don't, we would never think of anymore. Edvard Munch, best known for The Scream, had many personal experiences with medical care of his own. This is titled On the Operating Table. It's from 1902. And it, again, in the thread of the theme that people are painting the things that matter to them, the things that are immediate in their environment. He was sort of haunted by his own and his family's interactions with medicine. This painting I picked out on just to indicate, again, he's in an operating theater. It's starting to look more familiar. There are spectators, but they're in a separate room. They're not actually in the operating room anymore. Art has always been a means of healing. And again, you're painting the things that matter to you and that matter to the people around you. And our health is one of those deeply personal and deeply critical things. Backtracking very far into the past, we see religious sculptures that have been found in Etruscan and Roman ruins. These are, in the literature at least, these are called polyvisceral ex votos. So an ex voto is a religious figurine, a votive object that was given to a temple as a prayer for or in thanks for a medical outcome. And then polyvisceral, these specifically are showing many of the contents of the abdomen of the thoracic cavity. It's fascinating to me that in the 3rd and 2nd century BC, we still see, fairly recognizable heart, lungs, esophagus. I'd call that the bladder. On this, I'd call that the colon. Things that, still look familiar to us today. This theme of religious art, although it probably developed separately, continues from Spain and into Latin America after Spanish colonization. And we see a theme of retablos, which again are paintings that are given in thanks for for a prayed for outcome or a miracle. And I'll talk about these as we go on. This is a retablo from 1777. And the text in Spanish at the bottom, I'll abridge it, but Doña Josefa Perez Maldonado offers this monument of her gratitude in perpetual memory of the benefit that resulted from an operation when the surgeon removed 6 cancerous tumors from her breast in the presence of the gentlemen and ladies depicted on this canvas. So I have gone back in time here a little bit. This is the 1770s. We're not in an operating theater. We're not sterile. We're not, where the public is present, and we're not anesthetized. And she's undergoing a mastectomy. That this particular retablo is notable for sort of the graphic depiction of surgery that it contains. These retablos are an art form that are still practiced today, which I'll bring through in a moment. Francisco de Goya is a Spanish painter known for some of his other works. This is actually a painting at the Minneapolis Institute of Art, if you want to see it. It's titled Self-Portrait with Dr. Arrieta from 1820. And it's his physician nursing him back to health. And again, in this format of the retablo, offering thanks to his physician for bringing him through this critical illness and through his suffering. We see direct echoes of this in other artworks in more contemporary times. Frida Kahlo, Self-Portrait with the Portrait of Dr. Farrell, echoes this, and thanks to her surgeon for some of his medical care. Rigoberto Torres is a contemporary artist and a sculptor, had multiple asthma attacks that left him hospitalized, and he created this sculpture, and thanks to his physician afterwards, is a direct rhyme or a direct echo with the Goya painting. Frida Kahlo is a very well-known surrealist artist, and her work is heavily autobiographical and focuses as a way for her to explore her own medical illness and her own pain. She was actually intending to become a medical student and was in a bus crash that left her with severe spinal damage. She had multiple spinal surgeries over the course of her life. And her work is characterized by self-portraits that, in a surrealist theme, but very personally represent exactly how she's feeling and exactly the suffering and the struggle that she's gone through in her own medical journey. Broken Column is perhaps one of her most famous portraits, representing the many spinal surgeries that she had over the course of her life, also representing the medical corsetry that she had to wear, probably the analog to a TLSO brace these days, as a way to protect her back, and then the wounded deer, portraying herself as a wounded animal. Again, I mentioned that the format of the retablo is still in use today, and these are a couple of examples from the 1960s, both in thanks to a specific patron saint, in this case, the Virgin of San Juan de los Lagos, for bringing the donor through an operation safely. And the convention is, again, you have the sort of place where the miracle happened or the prayed for outcome happened. So in this case, the operating room, you have the dedication, and you have the saint to whom this is dedicated. Guadalupe Maravilla is a contemporary artist born in 1976 who was diagnosed with colon cancer in his 30s. And these works from 2013 and 2021 are in that retablo format, but are shift from the theme. The first is the dedication is to the radiation therapy machine itself. I wanted to thank the radiation therapy machine that killed my cancerous tumor. There's no saint here. It's just his medical care that he is offering this in gratitude. And then in yellow, this is a retablo format thanking, in thanks for his sort of second lease on life after he receives medical care. During this time of his illness, he reinvented himself as a person and as an artist. And much of his work now focuses on healing in both a physical and a spiritual sense, echoing both traditional indigenous and Hispanic healing practices as well as modern medical practice. And along these lines, art has always been in conversation with medicine. As we shift into modern and contemporary art, this becomes increasingly evident as art becomes something that is created for its own sake and not in service to a person who commissioned a portrait, or in service to a dedication to God, something that would be religious artwork in a church. These are two contrasting images from World War I. On the left, George Bellows' engraving titled Base Hospital from 1918, and on the right, Max Beckmann, who was a German artist, titled The Large Operation. And Beckmann volunteered for the German Medical Corps during World War I to avoid a combat position, and drew from life or immediately after life his experiences in German field hospitals. Bellows, on the other hand, was working based on photographs, based on descriptions of medical care that were happening in Europe at the time. You can see the difference between these two settings, that you can draw both from their different experiences and how they're seeing or how they're accessing this information about what's happening. Bellows' work shows a patient and a surgeon in the middle of a cathedral. Many of the cathedrals were used or converted to temporary field hospitals as they needed space for medical care. And the environment is much calmer. There's almost sort of a divine white light shining on the surgeon. And then in contrast, Beckmann is showing, kind of the midst of an active clinic. Somebody is on the OR table, somebody is on a stretcher, and this to me feels much more visceral, much more like what I would expect from a field hospital. So forward again to Damien Hirst, who I mentioned at the beginning of this talk. And he asks, or he says, I want people to believe in art the way that they believe in medicine. And he created this word, pharmacy, in conversation with that question. And it looks like a pharmacy. You walk through the Tate, you walk from one gallery to the next gallery, and then you enter this room and it's full of drugs and a table with somebody's record book and a pharmacy bag and a telephone. And the context shifts. But this question, sort of the aesthetics of medicine and the aesthetics of art and what makes us believe the things that we believe. We talk about the placebo effect, but if you had a placebo arm in a trial and it was literally a spoonful of sugar rather than a sugar pill that looked like medicine, would it have the same effect? He has, this room is filled with carefully arranged boxes of medication. They're real medications, but when you look at them in detail, they're not in any kind of order that makes sense. They're sort of arranged by color. They're not arranged by physiologic effect or treatment effect. And so, as you examine this, what makes you think that this is real or realistic, and where does that illusion fall apart? This is another work of his. It's titled Still. This is a sculpture at the Art Institute of Chicago that I've visited many times at this point. And again, the context of the sculpture makes it art or defines it as art in a time where the definition of art has become much more expansive. And so this is a cabinet full of surgical equipment. It's things that we recognize. He's got, let me get this mouse to work. He's got Hill-Ferguson retractors. He's got scalpels. He's got kidney basins. He's got Deaver retractors here. And what makes them art? Because we said so, because he said so, because they're in an art museum. But it's just something that's just always fascinated me, is that when you change the context of something and have this conversation between art and medicine, it can be transformative. Mona Hatoum is an artist of Iranian origin, and she kind of takes this to the next step. Her works, Corps Étranger and Deep Throat from 1994 and 1996, incorporate footage of her own endoscopies. And so she is commenting on the surveillance state of London that she observed at the time, and the sort of most primal, most visceral experience of surveillance taken to its extreme by saying, look, this is what it feels like. It feels like everybody is inside me looking at my intestines. I'm being surveilled so closely. And so both of these, Corps Étranger, you enter this sort of video gallery, and then the floor has playing video of an upper endoscopy and a colonoscopy. And then Deep Throat, likewise, as you see it from the side or across the gallery, it looks like a table set for one. And as you approach, the plate actually has a screen in it and is showing a colonoscopy. This is my photo from the Museum of Contemporary Art in Chicago, and for me, approaching that and seeing a colonoscopy was like, oh, funny. But I think, out of that context, or out of my particular context, if you're seeing that unexpectedly in an art gallery, that could really call like a visceral or a physical experience into question. Mary Duffy participated in a session of performance art called Vital Signs Crypt Culture Talks Back in 1995. She's an Irish painter who happens to not have arms as a result of a congenital defect. But during this performance, she draped and then undraped herself in a robe, and at one point directly echoes the Venus de Milo. And that asks, what do we call disabled? What do we call beautiful? How are those the same, or how are they different? Because the Venus de Milo is one of the sculptures that everybody quotes as, the Venus. She's the most beautiful sculpture in the world, one of the most famous sculptures in the world. And Duffy, in her interactions with medical care, is told that she's disabled, that her body is not normal or that is not beautiful. But why do we say that? Moving into the 80s and 90s, Roger Brown was an artist who lived in Chicago, was a gay man, and his partner was diagnosed with lung cancer in 1984 at the time of the second painting. Diagnosed in 1983 and died in 1984. These two paintings, Peach Light and Cancer, are both in direct conversation of his interactions and his partner's interactions with the medical establishment and their medical care. Cancer is mourning the loss of his partner, and Peach Light specifically quotes during the AIDS epidemic, people had Kaposi sarcoma. It was one of the most recognizable features of somebody who had an active, who actively had AIDS. And if you went to a gay bar or a club, often the light was tinged peach because it helped to hide the visibility of the Kaposi sarcoma lesions. And that's the origin of the title of this work. And a skeleton who is, referencing it as being at one of these events. But, you still have a person who wants to be engaged with their community and their society, even though everybody is suffering from this epidemic. Likewise, Felix Gonzalez Torres was a gay man working during the AIDS epidemic, and this is titled Portrait of Ross in LA. It's from 1991. And the work itself is defined as, or consists of 175 pounds of wrapped hard candy, which is the weight that his partner Ross had when he was diagnosed with AIDS. And the installation is allowed to vary. These are two examples from the Art Institute of Chicago, one in 2016 and one in 2024. They're installed differently, but the definition of the work remains the same. It starts as 175 pounds. Viewers can take a piece of candy. You don't have to take a piece of candy, but if you do and you participate in his work, which is characteristic of many of his works, you are also symbolically diminishing Ross's weight as he wasted away of AIDS and eventually died. I knew that this piece of art existed in the world. I didn't know that the Art Institute had it, and these are both my photos, or the three of these are my photos, coming across it in 2016 in the corner of a gallery when I didn't expect it. I took my breath away. And not necessarily in a good way. It's one of the saddest pieces of art I think I know. Keith Haring, again, extremely well-known, prominent artist working during the AIDS crisis. He was already famous at the time that he was diagnosed with AIDS. Well-known, successful artist, highly recognizable style. He had begun his art career with graffiti and with mural work, so not only was his work highly identifiable as his own, but it was also public and recognizable. And so as he is diagnosed with AIDS and he starts working heavily with ACT UP to spread, to discuss methods of AIDS prevention, trying to speak about this epidemic that's being ignored by the government at the time, more or less ignored by the medical establishment at the time. His work has a cachet or an authority to it that draws attention to the issue. This is a photo I took at the Walker a couple of years ago. This ignorance equals fear, silence equals death, fight AIDS, ACT UP is a slogan that you'll hear from the time. The top is another mural of his actually painted in Barcelona. All of us together can stop AIDS. And he has his characteristic figures, including, snakes and syringes and scissors of people trying to fight AIDS. ACT UP was an activist movement and an artistic movement, and Haring financed it directly, sometimes pulled wads of cash out of a backpack and gave it to the ACT UP organizers to support their movements. This is a photo for historic interest. This is a photo of a protester at Die-In outside the FDA. They were protesting the lack of attention to the AIDS crisis, the lack of action or prompt work to approve medications to treat AIDS and opportunistic illnesses. Herring's art, and when I talk about art as a way of healing and art as a way of expressing oneself and what one's going through, this is titled Unfinished Painting from 1989, and he died in February of 1990. This is one of the last paintings that he completed, and it's called Unfinished. And it looks unfinished. But in person, if you look at it, he has painted all of the black lines and all of the silver lines over all of the purple drips. He dripped all of the purple onto the canvas. He drew his characteristic line drawings over it. He continued all of those line drawings onto these strips. And to me, you know, that's a man who is furious and sad at his life being cut short, at other people's lives being cut short, and expressing it through his art. And to me also, my overall argument for us is go to a museum, find something that you like, and stare at it. I didn't know that this painting looked like this until I saw it in person. And it can be really rewarding, even if all you get out of it is a sense of joy that you've seen something beautiful. Okay, baby photo time. So this is the About Me section. My parents, Gary Kohn and Susan Berry. My dad grew up on a farm in Nebraska, a very small town called Guide Rock. His parents, Alex and Claire Jean Kohn, lived on the farm until they retired. Photo of me with one of their piglets. They raised hogs. I was afraid of the piglet, I think. And my mom, Susan Berry, grew up in Glenview, which is one town over from where I was raised. She went to Notre Dame. Oh, and I should say my dad went to University of Nebraska and became a high-rise architect. My mom went to Notre Dame and then worked as a banker. My mom's parents, Catherine and James Berry. Some photos of me and my cousins here. This is my parents on their honeymoon and then them at my wedding. I have a younger brother, James. Mom and dad have taken us on, you know, trips and shown us a lot of the world, and a lot of. I draw inspiration from their dedication and their. I'm blanking on the word that I want, but grit and determination. My dad, you know, grew up on a farm and became a high-rise architect. That takes some inspiration from somewhere. I do take after my father. This photo in the bottom right corner, I'm told I look like him. I showed up to 4th of July and we were dressed in the same outfit. Doesn't usually happen, but you know. I grew up in Wilmette, Illinois, which is a suburb of Chicago. It's most notable for being the home of Seth Wolpert. It's actually most notable for the Baha'i Temple, which is one of 7 in the world. And Home Alone was partially filmed in Wilmette. The church scene in Home Alone is where I went to preschool. I had a happy childhood. I did actually have a very happy childhood. Some baby photos. This is my younger brother, James, a couple years younger than me. My parents have somehow managed to only document the times that he tolerated my presence. And now he lives in Seattle and is a geologist. You know, drawing back to Dr. Chipman and quoting me as wanting to go to the cafeteria for a reason to live. I like food. I've always enjoyed cooking and baking, and that even goes back to visiting my grandparents' farm and picking strawberries and radishes. And now my in-laws have a Swedish Christmas cookie baking tradition that I have been co-opted into, so this continues. I've also always loved art, and you know, you can see my childhood French Impressionist phase in the corner there with my little beret. I do still draw sometimes, but most of what I do is photography. A picture of me with an old manual camera as a kid, and then that is, in fact, my bird watching camera with the giant zoom lens. Um, you might note in the middle, I look crabby. I'm at Versailles, and there was a sculpture exhibit of a contemporary artist whose work I really dislike. I did not want it to be there, and I was really mad about it. And on the far side here is the first time I went to a museum after the pandemic shut everything down. I went to the Walker Art Museum for a show of prints by Jasper Johns, and this was on my dating profile, and I'm pretty sure is why my wife talked to me in the first place. Went to public school all the way through. My upbringing, I've got my classic backpack photos. I went to New Trier for high school. It's famous for being, it's a public school in the suburbs. Mean Girls is based on New Trier. All of the places that are cited in Mean Girls are real places in my town that I've been. And when I tell people that I graduated from high school wearing a white dress, they assume that I went to some like cheap private Catholic school, but I went to a very weird public school. I went to Notre Dame. My mom also went there. They decided that legacy admissions meant that I needed to live in the same dorm as she did. Don't know that that was entirely necessary, but I lived, this was my dorm, Lewis Hall, and it was right behind the dome, which was helpful for trying to figure out where home was when I was finding my way to the campus. I got a degree in biology and a minor in anthropology. I took 2 gap years before going to medical school. I wanted to make sure that I was making the right decision. And then I enrolled at the University of Illinois. This is match day, having matched to some place in the Midwest called the University of Minnesota. I didn't know that I was going to pursue colorectal surgery, but in retrospect, there were some signs. I fenced all the way through high school and college, and I focused on the fencing event that is the fastest, most decisive, most violent, probably. Every time I've told somebody that I was a saber fencer, they're like, oh yeah, now you're a surgeon. The photo of me in scrubs is the first time I ever observed a surgery. I was absolutely beside myself. And then I have a couple of Halloween costumes, including myself as the Da Vinci robot. As for the colorectal part, again, I didn't know that this was going to be my true passion in life, but my undergraduate thesis was looking at macaque population genetics, and the non-invasive way to collect DNA from primates is by stool sample. So I did a field season in Singapore, picking up and storing and freezing poop, which I also did in my lab years a couple years ago. This is a macaque named Julia. I actually got renamed to Julia for the duration of my research because macaque Julia had been there first. And I was pleasantly surprised that doing microbiome work meant I didn't have to be quite as rigid about sterility, because in primate work, if you contaminate something inadvertently with your own hair or skin or anything, the DNA is similar enough that you'll mess up your data. This is my wife, Leah. I met her second year of residency during the pandemic. Best call shift of my life. Shelby and I watched 5 episodes of The Haunting of Hill House, and I started talking to this girl on OkCupid. Leah's an artist and a jeweler, and I should thank her for the massive assistance that she gave me with this talk, which is extremely her wheelhouse and not my own. She's very outdoorsy, she's very active, and the longer I know her, the more photos I take of her, the more I realize that I'm just copying photos of her from when she was a child. These are all photos from her family's cabin in the Boundary Waters and our Boundary Waters trip, which I'm fortunate that she shares this place that she loves with me. Some more photos of us. Because we were dating in the pre-vaccine pandemic, we were actually not supposed to be socializing outside of our own households at all. So the fact that we went on masked, distanced, outdoors walks in November and December in Minnesota was technically, if not illegal, at least ill-advised. But I liked her. And she liked me. We got engaged at the cabin. We don't go hunting, but we didn't want to be mistaken for deer that day for some reason, so hence the hunter orange. And then my family, as a result of this, my family has grown over the last 7 years that I've been here, and I'm so happy and so grateful for all of them. My brother is engaged to his fiancee Katie. My parents and Leah's family have embraced me and Leah and everybody else who was joining our, my personal extended family is just growing, and they've been a real source of support throughout residency. As far as thank yous go, first and foremost, my co-residents, I chose this program based on the people. That was, interviewing, this is the place that felt most like people I wanted to work with and an environment that I wanted to be in. My intern class, we tried to stay in touch even when we were supposed to be socializing. We were supposed to be socially distanced during this photo, don't tell anybody. We've come to each other's weddings. Also, specific shout outs to Sonia Boatman, who preceded me in the research lab and was a huge help, and Dr. Nugent demonstrating how to function on a Methodist call shift, ensure in one hand, iced coffee in the other. Thank you for cutting the mullet.
I almost used that picture, but
I was not going to let it go. This was in a patient chart, and there's no information, there's no PHI in it, but patient is asked how he is. He responds Gucci, which is right reports means good or thumbs up. He perseverates on this phrase and continues to say it, does not answer other questions. If I had a nickel for every time Dave signed a patient out to me at night as Gucci, I would be much further on my loans than I currently am. Intern Journal Club, aka Happy Hour. One of these books is upside down. Helping each other create increasingly arcane poly stomachs from one stomach in a skills lab. Feasting on the last day of nights. I did not stop eating animals, even though Matt Wheelwright tried to convince us all to do that. And I'd like to thank all of y'all for encouraging me to get tested for sleep apnea, which I do have, so stop making fun of me. In Chief's talks in years past, everybody uses the same photo of their graduating class with one person badly photoshopped in. Our class has not one but two separate events on different dates where all 8 of us were present in the same place and there is no Photoshop involved. And I will brag on this. Thank yous on a system-by-system approach. The university has offered me the opportunity to understand myself and develop the sense of humor required of a colorectal surgeon. The support of the fellows at night can't be overstated. Where the F did that all come from on that free air. Really gave me the opportunity to hone my clinical decision-making skills and my confidence in myself. If you observe, this is one patient chart. I have written all of the notes on this patient's chart. I consulted myself twice overnight. Consult from me to me, callback number me. Really felt supported in that moment. And clinical units, nursing units that really understand my clinical decision making. This, you can't read it, says, it's a Belmont, it says, "This is clean, please leave to ward off evil," which is how I function. I'm not going to name everybody because I would run out of breath, but I'm so grateful to all of the surgeons here and everywhere that we work for their guidance, their teaching, specifically the Dr. Arsenatis and Dr. Jahansus for their research guidance. At Regents, I'd like to specifically thank Dr. Meyer for the importance of setting boundaries. This is probably illegible. He posted how to get at haiku in our workroom, and then the bottom says, note, TikTok is way better than haiku. Do not stalk patient charts or the OR board during wellness time. I also want to specifically honor Megan Goff, who to me embodies and teaches the importance of asking for help, especially from the neurosurgery APOL. At North Memorial, again, the first surgeon who let me on the robot console was Dr. Gibson. Surgeons who have encouraged me and helped me figure out how to operate in a more fast-paced community context. And again, learning the importance of clear communication here from Dr. Nugent. This was listed as a case on the OR board. HRA, rectal EUA, prone position. Exam under anesthesia of the anus with high-resolution anoscopy. An anoscope is just the anal retractors we have in the EUA tray, like the trap bivalve. For the HRA part, I just need acetic acid vinegar 5%. Please stage vinegar with case. I really hope you didn't have to consent the patient to all of that. And the Methodist, again, high volume, fast-paced community setting. One of the things that I've always enjoyed about this program is the ability to see different clinical contexts and figure out what I want for my career. And Methodist has been especially helpful in that regard. And last but not least, the VA for recognizing my attentiveness as a surgeon, and all of the times that I came to immediately assess the patient immediately. I love it when that gets documented. And I could not find decent photos of people, but that's Dr. Majumder, Dr. Johnson, Dr. Druck retired before many of you started. That is a lifelike image, I can promise you. I coached it from somebody else's chief talk, and Dr. Brahma, who was terrifying, but in a way that meant that she really cared about you. And last but not least, everywhere we work, I've had such good experiences with hospital staff, the consulting services, and they really understand how to work with surgery residents, I've found. Disregard last page, have a good night. Ben and Jerry's in the lounge. If you're still here, cake will be ready in 5 minutes. This is how you treat me. Next year, I'll be doing colorectal surgery at the Leahy Clinic outside of Boston. You can find me there, or at the local Audubon birding sites, or the local art museums, or maybe just stealing snacks with a colonoscope out of the physician vending machine. Thank you all very much for your time, and thanks for being my colleagues. Dr. Nugent.
Dr. Kohn, what a lovely talk. It has been such a pleasure to get to know you professionally and personally, and watch you grow in both of those areas throughout your residency. My question, and great talk, my question for you is, what is your favorite museum ever? You have to pick.
I'm going to say the Art Institute of Chicago. It is actually known as one of the best art museums in the world. It is an amazing museum, and it has it didn't come up in this talk, but one of my favorite physical spaces in the world is an art gallery that was designed by a Japanese architect. It's very, very dim. They have sort of a characteristic Japanese column structure in one part of the gallery, and then they have usually elaborate painted and drawn screens on display. It's calm and quiet and peaceful, and that's where I went the day before step one and just had to sort of chill out for a minute. Strong pitch for the Walker and the Minneapolis Institute of Art, though. Mia is free. If y'all are interested in doing something different that doesn't cost money on a day off.
I can't think of a good question, but just a comment that it's been a real pleasure to work with you all of these years. I remember distinctly meeting you. Julie and I went to medical school together, but she was a year ahead of me, and so I remember meeting you in like the workroom at UIC, and then to work under you as my junior resident when I was an intern, and then now to be colleagues graduating together. It's been a real joy to see you grow over the time, and I'm proud to be your colleague.
I'm proud to be yours. I remember meeting you at the pre-interview dinner. You were the last class of people to interview in person.
Yeah, and I spilled a beer on you.
That's a good.
I was leaving the door open. I wasn't a fan.
It's too late to kick me out.
I should probably let Dave get started, but thank you all.
Right. I think, again, everyone probably knows me. I'm David Leishman, also one of the graduating chiefs. Might not recognize me. I don't have my mustache or my mullet anymore, but COVID was a good time in some ways. The title of my talk is One Size Doesn't Fit All. And specifically, I'm going to talk about ergonomics, surgical ergonomics. I started thinking about this stuff when in lab, I decided I'll try to ski for the first time, and it was negative 15 degrees, and an old man took out my legs, and I broke my shoulder. I was like, oh crap, I'm not gonna do surgery anymore. And after that, I started thinking a little bit more about how I take care of myself, and that also includes how I take care of myself. So ergonomics, what is it? It's Greek. It stems from the words ergon, meaning work, and nomos, meaning laws. So it's the science of work. The International Ergonomics and Human Factors Association in 2000 made a definition that's quite long, but it's scientific discipline understanding interactions among humans and elements of a system, and it applies different methods, data, and theories to optimize human well-being and overall system performance. It's a mouthful. The NIOSH, the National Institute for Occupational Safety and Health, it's under the CDC. They define ergonomics as the design of work tasks and job demands to fit the capabilities of the working population. So, to put it simply, it basically means fitting the job to the person and not necessarily the person to the job. I think about as surgeons, we try to fit ourselves to the patient or the job or make ourselves adaptable. We love to say adaptable or be adaptable. So this is interesting to me because that might not be the most ergonomic. So the goal of ergonomics is to reduce and prevent musculoskeletal disorders caused by multiple factors. So those multiple factors include things, obviously the physical, work tasks, but also psychosocial, mental well-being, social factors, and personal things, which might not always be able to change or modify, so age, sex, BMI. But in other terms, it's just a way to reduce injury while work. So just briefly on the history of ergonomics. So actually in 400 BC, before the ancient Greeks utilized ergonomic principles in how they designed tools, their jobs, and how their workplaces. Hippocrates actually documented his thoughts on efficiency, and specifically he talked about in a surgeon's workplace how things should be set up and arranged and designed in terms of his tools. In the 1700s, there was a physician, Italian physician, Bernardino Ramazzini. He wrote basically a medical journal that outlined injuries related to working environments and occupations. These things are called things like Lever's bottom, writer's cramp, telegrapher's wrist, housemaid sneeze. And then later, in the 1890s, probably one of the first you could say modern ergonomic studies were performed. This was done by Frederick Winslow Taylor, and at that time, he wanted to improve productivity with workers. They called it scientific management. One example, and probably that study, the first study that I was talking about was in regards to coal shoveling efficiency. So he was an engineer, he worked at a steel mill, and he wanted to figure out how to increase the efficiency of shoveling coal. So he figured out that the optimal weight per load that the workers were scooping should be 21.5 pounds. And he tested different shovel shapes. And in the end, it led to tripling of the coal that was shoveled. And it also subsequently helped to reduce work-related injuries. Now, that is good, but his goal was productivity and not necessarily taking care of the workers. That was kind of an afterthought. Moving a little bit further in time, Lillian and Frank Gilbreth, they ran the time and motion studies. So they basically wanted to see how do I minimize how many motions I perform to execute a task. Seems pretty simple, but in one example, they worked with bricklayers who were able to lay 120 bricks in an hour, but by changing the efficiency of their movements, basically, and they use scaffolding to optimize height, working height, they were able to do 350 bricks an hour. The interesting thing about them, so they would break down each task into units. So whether it's grasping something, impact position, they called it thirblings, which is still used today to break down tasks, to analyze it. It's just their last name backwards. And then later in the 1900s and the 20th century, there's an increased interest in this scientific management, but there's a scarcity of funds. However, World War II then started, and there was an interest at that time. It expanded into complex machines and weaponry. And so designers started to take into account, they started to factor in the operators who were using these things. So they tried to limit human error and strain in those regards. And so from there was kind of a newfound or increased interest in scientific management, which later kind of became what we know as ergonomics. And in 1949, it was actually the first time it was termed ergonomics. And then the first societies, the Ergonomic Research Society, was founded, and that was in the UK. And then later in 1957, the US made the Human Factors and Ergonomics Society. So I know that was like super cool and interesting. But what does that mean? So ergonomics as an actual field or a science is relatively new, despite incorporating these things since ancient times. But to actually study and think about it in a scientific manner is relatively new. Industry has been using this for a long time, and it helped them increase productivity, which equals more profit, right? But ergonomics in surgery is even newer, and it's really only started being studied in the past couple decades, but it is growing, and the research is growing, and what people are doing about it is also growing. So the goal is hopefully we stop looking like this, bent over and twisting our whole body or hunched over in the OR. So why does it matter? The thing to just quickly talk about, because this is kind of how most studies measure injuries in the workplace, and also this is what's reported to OSHA, so it'll kind of make sense as I go on. But work-related musculoskeletal disorders, musculoskeletal disorders in general, MSDs, what it sounds like, disorders of the muscle, nerve, tendon, ligaments, etc. WMSDs are work-related disorders, and so these are the ones attributed to the work environment or the performance of work, and these are what are actually tracked by OSHA and then the NIOSH CDC. and in theory helps guide standards and change guidelines. So to get into it, why it actually matters for people like us. So this is a 2018 review in JAMA surgery. This is just looking at the prevalence of work-related musculoskeletal disorders in surgical interventionalists. So there was 126 articles they saw that discussed work-related musculoskeletal disorders. The majority of those, 101 of them, talked about ergonomics or interventions, but didn't really have any data behind it. 16 talked about the prevalence of work-related injuries, and 18 talked about the prevalence of work-related pain. So combining those, there were 5,828 physicians included in this. Of the total 126 articles, the majority, 75% of them, were in general surgery, OBGYN, urology, and ortho. And then there was actually a pretty even split in MIS and open. So specifically looking at work-related injuries. So of those 16, 13 were eligible for the analysis. So that's 4,200 physicians, mostly orthopedic surgeons, interventional cardiologists, and general surgeons. And these are forest plots. You don't really need to look at them, but these are the numbers. So specifically, these are the overall career prevalences of different injuries. So for degenerative cervical spine disease, 17%, for lumbar spine disease, 19%, for rotator cuff injuries, 18%, and for carpal tunnels, 9%. So, 10% carpal tunnel roughly, and then over 15 to 20% some other back or shoulder injury. In terms of work-related musculoskeletal pain, 12 of the 18 studies were able to be used. That's 2,800 physicians, and they use different tools that are validated, but what they were looking for was the 12-month prevalence of injury. So neck pain, 60%, shoulder pain, 52%, back pain, 49%, upper extremity, 35%. So what that means, injuries and pain frequently impact surgeons and interventionalists, and over 50% or more have back, neck, or shoulder pain, which I'm sure people have experienced in this room. And then at least 15% of them have experienced some injury as well. There was in some of these studies, in 10 of the studies, there was a measure of the disability burden of these injuries. Few studies report this, but this is the first time really looking at, well, what is this impact? And when they calculated, in those studies, there was 2,300 physicians, but of them, 12% of physicians required a leave of absence. They had to restrict their practice, or actually it led to early retirement due to these injuries. And a thing to think about is it's not just as an attending this happens. This starts earlier, starts in medical school. Some of the numbers below are a little different, but the thing to remember is, you learn habits as early as medical school, surgical residency, it continues, and then that's what you're doing as an attending. So it's something to keep in mind. So this is a study from the Journal of Surgical Research in 2014. This is looking at specifically the Tennessee chapter of the American College of Surgeons. They sent out red cap surveys to people, to different surgeons. 33% responded, which is pretty typical of survey studies. The majority were general surgeries, general surgeons, the majority are male. The one thing to take from this is just, in their small study, they didn't see any specific risk factors related to demographic or lifestyle, but also that there was no evidence of increased injury with more years of experience. So the more you work doesn't necessarily, at least in this, doesn't necessarily mean you have a higher risk of injury. 40% of these surgeons responded that they sustained a injury in the workplace during their career. 30% indicated that they did not know how to report an occupational injury. I don't know about you guys if you actually formally know how to report. I don't, but I didn't. Now I do. 25% said safeguards to prevent injury were inadequate. And then 21% reported that resources to support surgeons after injury were inadequate. Here, again, kind of highlighting what the other study showed, the most common areas of injury: back, neck, hand. The median level of pain was 5 out of a scale of 10. Not insignificant. And then over half actually said they had pain related to this injury for over a month. And 66% of the surgeons attributed this to chronic causes, specifically including strain from their operating posture. What I find most interesting is in this box, it might be hard to see, but 49% of the people, of the surgeons who received medical treatment, only 19% of those actually reported it to the institution. The other thing to think about is these injuries led to 35% of these people had fewer operations as a result. They were performing fewer operations as a result of these injuries. So less than a fifth of surgeons who self-report having an injury report this to their institution. And this is both in academic and in private practice. This was seen. Many, again, do not know how to report an injury. Now, we don't know exactly why surgeons don't report these things, but you can kind of extrapolate from other studies. For example, there's needle stick studies in surgeons that some say only 2 to 10% of surgeons actually report these. And even in residents who are more likely to report things, that's less than 50%. They always say the number one reason is a lack of time and not wanting to deal with the paperwork, which I totally get. The other thing to think about is just kind of who we are as surgeons and what the surgical culture is. Self-sacrifice is woven into our culture, as well as being tough and not complaining. But this leads to probably a gross underestimation of the actual number and degree of injury that occur to surgeons specifically. So it's obvious that injuries are happening and happening more than we probably know. And we often don't feel that the hospitals care about us as physicians. But the thing hospitals do care about is money. And injuries lead to decreased performance, decreased productivity, which leads to decreased profit. And so that is something they care about, right? So what is the cost of injury? More people are disabled from working and the WMSDs from working than any other disease. The Department of Labor puts the numbers as 62% of all worker injuries are WMSDs, and 32% of missed days are attributed to this as well. Some studies have looked, and they've actually found that WMSDs, work-related injuries, are the number one cause of absenteeism in healthcare workers. And in 2022, the CDC estimated the cost of work-related musculoskeletal disorders as $15 billion a year, and it's 25% of workers' comp costs in the U.S. So the unfortunate thing is, where it is in research right now, the economic burden of WMSDs in physicians is not reliably defined at this time, but we can extrapolate to some degree. So this is an article from David Rogers. He's a pediatric surgeon at the university, at UAB. He's also their chief wellness officer, and he wrote for the American College of Surgeons talking about wellness and surgical education. This is an excerpt from the article in regards to how both surgical learners and teachers often neglect basic human needs for themselves, but they do this for their patients. So, he says patient care may require a short-term sacrifice of what most reasonable people would consider basic needs. Unfortunately, the surgical culture has celebrated this type of deprivation and will need to be shifted to one that balances necessary sacrifices with the science of stress and wellness. It's important to remember the most basic needs are physiological, and he goes on to talk more about this, including about how this was impacted during the pandemic. But again, this kind of pops up. The surgical culture has often celebrated this type of deprivation. So self-sacrifice, again, is woven into the fabric of surgical culture. This is a 2019, this is a physician, inpatient, outpatient revenue survey. So this, let's see here, this is actually the estimated average revenue that a general surgeon in 2019 brings into a hospital in a year. So 2.7 million. I also put some other surgical specialties, so you can see here. Again, there's very little data about how long surgeons who get injuries are actually out when they do take time off. The previous study I showed was one of the only where you can actually find some time, some frame of time, and it's usually around a week. People take off if they're taking off based on that. So if we look at the revenue from one general surgeon in a year, and let's say they take a week off, I'll show you here, that's 52,000 lost revenue. Short-term disability is typically anywhere from 3 weeks to 6 months. At the university, at least as residents, the GME policy max is 3 months. So if you take 3 months off, that's 624,000 in lost revenue, which is quite a bit. So again, the other thing to think about is this doesn't necessarily take into account what I said earlier, the impact of injuries and reducing the number of surgeries someone is performing. So that was 35% stated they were doing fewer surgeries because of an injury. And actually 52% of surgeons stated that there's at least some impact on their surgical performance related to this injury. So if anything, hospitals should have an incentive to prevent work-related injuries in their surgeons. So what's actually going on? I've talked a lot about injuries to surgeons exist, some of the costs. Part of it, in order to figure out how to prevent or fix these injuries, we need to know what the problems are. But before we even figure that part out, we need to be able to identify and study these problems. So I said it previously, research is growing. And so here's some of the ways we perform the research in surgical ergonomics. Most of the studies, if you haven't been able to tell yet, are survey studies. These obviously have inherent biases, some retrospective studies. Most rely on subjective research tools, and these are scales or questionnaires. This is one, for example. This is from a review. You don't really need to read it, but it's just all the different scales that people use or different questionnaires or surveys they try for surgical ergonomics. One of these, body part discomfort scale, rates discomfort in different locations on the body on a 5-point scale. This has been validated. This NASA TLX was made by NASA, and it makes workload scores and tries to look at incorporating different demands on the body: mental, physical, temporal, performance, and frustration. And this has actually been adapted for surgery. It's called the Surgery Task Load Index. And while these studies are validated, or these tools are validated, they are subject, again, to biases, recall bias. And for example, someone's discomfort level that they experience may not actually correlate to actual demonstrable tissue effects, right? So these are some of the scales here. The one on the left is the pain scale, and the one on the right is the surgery task load index. These are both great, obviously, and would be very fun to fill out. Another thing that people do that is used in the surgical ergonomics literature is video analysis. So directly observing surgeons using cameras. This is either in live setting or simulated surgery. These observers then analyze the videos using standardized scoring systems for ergonomics. A couple of them are the RULA, the RULA. That's for upper body assessment of strain. And then the REBA, the rapid entire body assessment, looks at, takes more into account the differences, the changes in static posture and dynamic positioning. And this is an example of a REBA assessment worksheet. Again, if it's not obvious, video analysis and using these scales is very intensive and time consuming and is really subject to inter and intra rater variability in their interpretations. So obviously objective measures would be good, but there are difficulties with that. So sensors or postural tracking devices. These are nice, but they're challenging to set up in a live OR setting. If you're trying to test something on the forearm or the hands, it's difficult with the sterile field. The wiring, the setup can be cumbersome. Same with EMG studies. There's been some optical and kinematic tracking systems. So they put reflective markers on joints and you can track the movements with a optical tracking system, but it's limited by things whenever the markers get blocked or, again, applying in a sterile setting. Despite that, there are people have made progress in this, and some of these sensors and devices have made improvements in their usability and are being utilized in some fashion. So this is just this is one example in the Journal of Neurosurgery. Main thing I just want to highlight. So these are, I don't know if you can see it well, but on top of the head of this person in A, that's an actual sensor. So this is a inertial measurement unit. It's called an IMU. And this study, they were basically just showing that you can assess posture by putting it one on the head, and then they also put it on the back of residents and neurosurgery attendings. So you can measure the degree of flexion, extension, also how often your head is pointed down. And this was actually taken a little bit further. So in this study, this is a pilot study using a posture trainer. It's actually commercially available. It's called the Upright Go 2. And so this is an example of the setup here, but the benefit of the device is that it collects data for posture, but it also provides a vibration if you're outside of the parameters. So it reminds you to actually stand up straight again or avoid being in so much flexion or extension that hopefully you reduce your risk of injury. This is the setup. So they have the device, the monitor, where you can see what's going on because there's an app for it. This is them using it in the OR, and you can see in the bottom left, that's actually where you put the sensor, just in the upper back. And this actually, it collects data for posture, and then it's used the REBA scale that I talked about to assess the risk of developing MSK disorder and your time in suboptimal positions. So in this study, the vibration from the device when you're outside of optimal position was actually beneficial. So in the intervention group, they had a reduced time in suboptimal positioning 50% versus basically 21%. And anecdotally, everyone in the study stated that they felt better, less pain, etc. A similar study was actually performed in the Annals of Plastic Surgery, And that showed that 72% of surgeons spent less time in suboptimal positions when using this device as well. So this is like literally something you can buy online. Yeah, so feel free.
Do you have the website for that?
Yeah. Upright Eagle 2. So we talked about this like optical tracking, and we do video analysis and stuff. And so I think naturally the next question is, okay, well, what about AI? So this study is from 2023, and this used an AI app from Kinetica Labs. And it was used as a way to perform sensorless measurements of the joints and joint angles. So the app used both the Rula and the Reba scale to perform the video analysis. So in this is just a small study, but they took residents and they assessed them pre-intervention. So asked them questions about ergonomics and what they know about it. And then they did like a score curriculum, a group discussion, and they were before those interventions, they performed simulated tasks with the AI app, and then after the intervention, they again performed the interventions and were watched and observed by the AI app. And so here there was a statistically significant decrease in time in unsafe positions after the intervention. 22% had less neck and 7% less shoulder time in unsafe positions. And 100% of the residents expressed interest in increased formal ergonomic training. This here, you can see these images are actually stills from the app. So you can see where your body is in space, and the red is obviously when they're in a bad position. So you want to be in the green. And this is subjective rating pain. So 36% to 14%, so decrease in cervical pain, and right shoulder pain, 9 to 2%. This app, Kinetica Labs, it was a startup at the University of Michigan, but they actually got bought, and this app got bought by a bigger corporation that actually is using it for AI analysis in industry now. But there's a bunch of other apps like this you can find. So, like I said, there are multiple verified tools and surveys, but they are subject to bias. The introduction of these newer and better wireless and improved posture trackers for surgery is beneficial, but there's still room to grow in that space. And again, AI software may be useful in video analysis to improve objectivity in these studies. I found two recently. There's an ongoing study with SAGE's, actually, their ergonomics task force. They're using a different AI software to track ergonomics at this point too. So we've looked at how you can actually measure and research ergonomics and whatnot, but how do you identify after you look at these things, you want to figure out, okay, is there a difference between the approach, so open, lap, robot? I was thinking about it, and I came across this when I was contracting stuff. And I think everyone, probably some residents, still try to figure this out. So in some studies, looking at different approaches, basically open versus lap versus robot, there's a range, 66 to 94% of studies found WMSDs in open surgery, 73% to 100 in lap, and as probably most would expect, 23 to 80%. That's a big range, but in general, it's less in robotic surgery. In this study, looking at 1,400 surgeons, they compared the pain after open lap or robot surgery. And here, 55% attributed pain to laparoscopic surgery, 36% to open, and 8% to robot assisted. I think that it might seem counterintuitive when we think about laparoscopic surgery and minimally invasive surgery. It's minimally invasive, so it's better for the patient. They have smaller incisions. So I don't know, me at least, I tend to think, okay, it's probably better for me too. But it's actually, in multiple studies, has been shown to be associated with worse pain and injury compared to open surgery. Robot-assisted surgery or robotic surgery is considered more ergonomic, and it is associated with less pain and injury overall. There's still some pain associated with the cervical spine and shoulders, but you're less likely to have pain in your back or your legs. But there's a unique pattern of finger strain and actually eye strain from looking into the console. So something to think about, but this is a good example, and sometimes I find myself on the robot. What I'm doing is slouching and your arms up, your elbows up in the air. That happens often if you're not clutching, and definitely can make your shoulders really tired. So something, again, to pay attention to. This is F. Jacob Siegel. He's an ergonomist and human factors researcher from the University of Michigan. He published and presented this paper, Disparities Between Industrial and Surgical Ergonomics, at the 2012 International Ergonomics Association World Congress. He makes multiple points on how surgical ergonomics have basically lagged behind industrial ergonomics. But in particular, he says this about minimally invasive surgery. Like I was saying, it's actually associated with more injury. But MIS, minimally invasive surgery, for example, faces particularly difficult challenges in MIS surgery. Procedures have been designed to facilitate minimal damage to the patient tissue. Unfortunately, the convenience to the patient comes at the price of a number of additional constraints on the surgeons. These constraints have resulted in ergonomic challenges to MIS practitioners. Some of the, when you actually think about, well, okay, what are the risk factors for being injured during surgery? What actually causes injury? These are kind of universally agreed on risk factors in the ergonomic and human factors fields. So force, repetition, repeating motions, awkward postures, static postures, exposure to vibration. A lot of these, especially repetition and the different postures, I think we all can see how that translates into surgery. Again, I would be lying if I said I don't look like this half the time during surgery. Open surgery itself, subject to awkward body position, standing, and at times the need to actually use substantial amount of force. One of the biggest issues is static posture, not moving, and then when you combine that with your head bent or your back bent, that has actually specifically been identified in neck and back injuries in surgeons. The other things to think about, loops and headlamps, those cause additional strain. And then the table width and height, we always talk about, adjust the table height to the tallest person and the new step stools. Does that always happen? Not necessarily. Exactly. And the other thing, table width, people awkwardly trying to maneuver around, arms out or tucked even sometimes. So laparoscopic surgery, like I said, it actually is associated with more injuries. It creates unique risks for surgeons. Similar risks to the issues with open surgery, but they also have additional problems. You have a static position of your head in your trunk when you're staring at the monitor. They've actually shown that you shift weight less compared to open surgery. That increases your neck and back strain. And then the fulcrum effect from when you're using laparoscopic instruments in the trocars, those are fixed trocars. So if you really think about what does that mean, you have to do really exaggerated wide movements to achieve really fine, tiny movements within the body. And again, like I talked about, table heights and the monitor placement are a big issue, especially monitors. The thing that kind of stands out is most operating rooms were designed with open surgery in mind and not necessarily laparoscopic surgery in mind. That obviously changes as we update our operating rooms, but the way our tables are set up and our monitors are set up, that often requires the need for steps or excessive arm abduction or your shoulders and elbows out. This often requires standing on one leg for a foot pedal. That's like the bane of my existence. I hate the foot pedal. I'm always on one leg. Good. And then the other thing is the instruments for laparoscopic surgery themselves are not great. They cause exaggerated ulnar deviation, wrist flexion, and again, that arm abduction, which you can see in this bottom right with the elbows up. And it's really difficult. You have to do some of these things just to get your fingers in the loops or your thumbs in the loops sometimes. So F. Jacob Siegel, the guy I was just talking about, he also previously quoted, he spoke on how basically we optimize our instruments for specific functions of surgery, and they're very good at those things. So we get all these new devices and instruments, and we pay so much attention to making those better for their specific function or procedure or whatever they're doing. For example, in general surgery, there's at least 162 classes of surgical instruments. So we're constantly adapting these instruments to meet the needs of the procedure or the situation. But on the flip side, there's very few variations in instrument grip, and there's little optimization in the handles. Talking about laparoscopy, there was a reported, it actually has a name, laparoscopic surgeon's thumb, from the poor design causing pressure on the digital nerve on the thumb. It was happening so often, they actually came up with a name for it. So here's an example also of what I'm talking about. So these are, if you look at these, those look like Mayos and some maybe pot scissors, and these are from actually a Civil War surgical kit. So there's not much change in the design of these handles. And another way to say this is the majority of customization takes place on the sharp end of the instrument, and not necessarily the end that we use as the surgeons or the operators. And remember, ergonomics is fitting the job to the person, not the person to the job. One particular way to think about this, or something to talk about, is hand size. So glove size traditionally come in 5.5 to 9. The average for men, glove size is 7.5, females is 6.5. And instruments are made one size fits all. It is well known that minimally invasive surgical instruments are fashioned for the 7.5 glove size, aka the average man's glove size. And smaller glove size has been demonstrated in many different studies and articles to increase pain, and it is a risk factor for musculoskeletal, work-related musculoskeletal disorder. So I asked all our lovely chief residents what their glove size was. I was like, this isn't a weird thing. But it works well as the majority, except for me, everyone in my class is all female. And so you can see they kind of cluster around the 6.5. We have some outliers with Melissa here. And then I wear 8.5. And so we have nobody who is at this 7.5. And from my perspective, I struggle with a lot of instruments as well for a different reason, but it just kind of goes to show that a lot of these instruments, they really shouldn't be one size fit all, right? And then you can see here, this is actually a study looking at a bigger population of surgeons and what the average glove size is. Here is actually more like 7. So none of this really fits. It doesn't fit for everybody. And it kind of brings up a point of specifically women in surgery. Obviously, a lot of these instruments and things were not designed with them in mind. I know it's sometimes hard to believe, but surgery was a very male-dominated field and didn't really take into account how women fit into it. So this is data from 2020. Was looking at the number of female applicants and female trainees in general surgery and vascular surgery training. So the dotted line is general surgery. You can see the number of female applicants in 2020 was over 40%. And then in actual trainees was between 40 and 50%. So the number of women in surgery, even in just general surgery, is increasing dramatically. I looked at the most recent ACGME data as well. And the past year shows that general surgery has 49.9% active female residents. And actually integrated plastics is at 52.4%. So there's more female residents in plastic surgery than male residents. Oh, I did write that. And just talk about it a little bit more. I could go on and on about it, but these are just some of the things that stood out to me. This 2024 review reported 77% of females had musculoskeletal issues related to the instrument use. In different studies, the range is 59 to 100% of female surgeons had more problems using surgical instruments compared to male surgeons who only said 13 to 56% had stated they had problems with using surgical instruments. Women are significantly demonstrate significantly higher wrist and shoulder activation with laparoscopic instruments, and this has been studied and it's known women's grip strength is 50 to 75% that of a man. What does this mean? It leads to issues using some of these laparoscopic instruments, specifically staplers, or even the harmonic has been implicated in different studies, endoscopy, colonoscopies. In this study in 2013, women attribute physical discomfort to laparoscopic operating comparable to men. However, women are significantly more likely to receive treatment for their hands, and the odds ratio 3.5. So, and even when you control for glove size, so women with larger glove size compared to men with the same glove size, they still required more treatment than their male counterparts, 21 versus 3%. And these findings have been replicated in orthopedic surgery, gyne, and other procedural based specialties. Again, talking about the stapler, we use it commonly in general surgery, and 78 to 92% deem female surgeons deem the stapler is hard to use versus 41 to 56% of male surgeons. Anecdotally, I find that thing hard to use sometimes. So, how do we fix this? So, there are different things coming out in talking about different ergonomic devices you can wear in the OR. This is actually in the plastic surgery literature. It's a review from last year out of Mayo Clinic. And it looked at physical support devices. So there's actually 6 upper body. They had exoskeletons, basically upper, lower. They looked at different support systems and posture training sensors. The one thing to point out, all studies reported positive surgeon experiences. And this is just looking at the different metrics they used to study. So self-reporting is still a lot, but they had other muscle activation or other objective ways to measure some of these. It's a little bit more helpful. These are just some examples that people are using. These are upper body exoskeletons, and they're passive, so they're not like powered or anything. They use springs to offload some of the force required by the surgeon. I think There's also an example of a passive lower extremity exoskeleton being used for laparoscopic surgery. This is a wearable arm support. It straps to the waist and you can support your arm. This is used in like endoscopic sinus surgery. And then this is a passive neck support. There's one I keep getting ads for on Instagram. It's called the neck spine, and that a lot of like neurosurgeons are using actually. So what about, what can you do now in the operating room? This is a really good review out of Mayo Clinic by Susan Hallbeck. She's the director of the Human Factors Engineering Lab over there. She's in this space a lot and has a lot of articles put out. So all those some of these images you might recognize I used are from this paper. They put it in a really nice way that you can kind of just understand. So overall, how do you want to be? You want your shoulders relaxed. You want your elbows and arms in. You keep your arm perpendicular to the floor. Some of this might seem intuitive, but we definitely don't always do this. And then you want to keep your neck. You don't really want to flex more than 30 degrees. You certainly don't want to be hunched over. And a big thing that we don't think about is the static posture. We stand so still. Movement is actually good. It helps prevent some of the stiffness and some of the injury and pain. This is just another example of how you should position yourself. Tuck patient's arm when you need. Try to keep a neutral head position. Use the anti-fatigue mats. And I think one of the things, again, talking about the foot pedals, ideally you have the foot pedal in front of your foot and you don't have to balance on one leg so much, because that's definitely one of the bigger issues with using foot pedals. In lap surgery, a lot of the things are the same in open surgery, but I think specifically with monitor placement, you want the screen to be at eye level or even slightly lower so that you're not craning your neck up to look at the actual monitor. And again, keeping your elbows in and not out, which oftentimes we're doing. Try to keep your working angle between your hands and your instruments 60 degrees. There's even something about how to use the console here. You can see some of this again is intuitive, but you want to be your thighs parallel to the ground. You want your knee, your thigh, and your leg to be at a 90-degree angle. And you want your back to actually be supported by the chair. You don't want to be hunched forward. And then, again, the slumped position here on the right, that is oftentimes how I find myself after I'm going for a while. But the big thing to take about here that I'm always working on is the clutch, ABC, always be clutching. I find myself needing to clutch more and more, so I keep myself out of those awkward positions. The researcher I was telling you about, she also created this OR stretch. It was an app, and it's something that they designed that you can actually stretch while you're in the operating room and between cases. I tried to use a link, and it doesn't seem like it's up anymore, but it's something, if available, you can look at. It just talks about doing some things you can do while you're scrubbed in, squatting, stretching your shoulders, neck roll, or shoulder rolls, and stretching your neck. This is just an example, kind of live, of what positioning should look like laparoscopic. Ideally, your posture should be. The other thing is this has actually been now extended into the ACS is taking this seriously. This is from 2023. They have a 17-page document on surgical ergonomic recommendations. They formed a committee, the Surgical Ergonomics Committee. I encourage you to look at it. It's actually pretty good, and they have good pictures and examples. These are just some that you can see. And they actually, at the end, have their own stretches and different things you can do intra-op between cases. there also is a newer society, the Society of Surgical Ergonomics. It was started it was founded in 2020, comprised of surgeons and ergonomists, and they have similar recommendations to the others, but this is like their call for abstracts, which if you want, you could try to do real quick. But the first prize is $10,000, so it's not bad. And then the other thing that the ACS is doing, like I said, a lot of residents and attendings in these studies said they would like more training, or they didn't really receive any. The ACS actually offers in-person training. They'll send people to teach. It's like 2 to 4 hours to actually demonstrate hands-on these ergonomic principles. So, in conclusion, surgeons experience these work-related musculoskeletal disorders at a rate likely higher than reported, which has implications on their career, the patient, and cost of the hospital. Our surgical culture of sacrifice for our patient is something that I think we're improving, but always needs work to put ourselves, actually care for ourselves and put ourselves forward. The research into surgical ergonomics is improving, but we still need some better measures. And I think we need to recognize that instruments are not one size fit all, and we need to fit the job to the person and not the other way around. Equal, if not more, female surgeons are now in certain subspecialties, and the instruments and operating room design need to be reflective of those things. Stretching and resistance training can be helpful for preventing some of these injuries. And as I showed, there are new devices coming out. These are just a bunch of the references. I don't expect you to look at those. So quickly about me. So I was born in North Carolina, in Jacksonville, North Carolina. That's at Camp Lejeune. My dad was in the Marines, and like most do, he met my mom overseas. My mom's from the Philippines, so my dad is John. My mom is Dolores. They got married pretty quickly, and the following year I was born. I think this picture is hilarious, early 90s. So I actually grew up there until I was about 4 years old. This is a picture, like the only baby picture I could find on short notice, because I didn't. My dad has most of the pictures, I found out, not my mom, which my dad can't find any of them. So it's just me going through a Bud Light box. When I was 2, or I wasn't quite 2, my sister was born. That's Sonia. And then this is a great picture of our family. And eventually, like I said, I was around 4 years old. We moved to Ohio. So my dad and my dad's whole extended family is from Ohio. We moved to the great Asbury Park. It's a trailer park. I grew up in a trailer for a long time. It was actually super fun. I don't know if you can see, I'm standing super awkwardly and don't know how to pose for pictures, but here's me and my sister riding a roller coaster. And like I said, the nice thing about growing up at a trailer park is there's tons of kids. So I hung out with a bunch of kids all the time. That's me on Christmas morning on time. I did Cub Scouts, and this is the Pinewood Derby. So that was my first year, and I actually got first place. I was super pumped. And then when I still lived there was when I first started my first sport, which was baseball. So that's just a picture of me playing. This is a picture of my all my family back in the Philippines. So my mom grew up in Manila and obviously immigrated here. She's one of 7. So that there's only one boy in all of that. So all of her sisters, they all have kids. So these are all my cousins, and as well as some of my aunts. And we were not having a great time. That's me. That's my sister in the front. So we were actually, here's part of the reason why we were not having a great time. My family in the Philippines is pretty poor. So, we're American kids. We're used to taking baths and showers. The kids, we had to go out and bathe at the water pump outside. So you can see the soap right there. My sister did not like that. And we went there initially. It was supposed to be a month. I was like 5 years old. Something happened to my mom's visa and her green card. We lived there for 7 months. So this is us at one of the huge malls in Manila. Manila is known for like their super malls. Yeah. So eventually we did make it back. And when I was in 3rd grade, we moved to my hometown, Geneva, Ohio. It's not Switzerland, but pretty close. This is a view. So it's also called Geneva on the Lake because literally we're right on Lake Erie. And it's kind of like it can be a touristy spot. I don't know the type of people who want to go there, but in the summer, like this Eddie's Grill is like one of the really popular places to go in the summer. This is one of the big arcades we used to go to, and Geneva is known. I don't know if you can see it, but we have the oldest miniature golf course in the U.S. to continuously operate. So it's a pretty big deal. The other thing that made it famous was we're Ohio's wine country. And this is like no joke. Like, we're known for our ice wines, so we had like so many wineries throughout my town. And then every September we have the Grape Jamboree. We celebrate grapes. So everyone you can see here is in their purple. And we have the Miss Grapette pageant and grape stomping. I used to help with the grape press. We would press fresh grapes for fresh grape juice. In the middle of all that, one day my brother was born. I was like in 7th or 8th grade. So that's him. And then as I went into high school, I played sports throughout. I wrestled, played football, more football. I was my senior year. I was an all-state defensive end, so that was pretty cool. And then this is a really cool picture of me at prom. I went to college at Case Western. It was only an hour from home. I was the first person in my family to go to college, so I wasn't really sure like what I was doing, and I wanted to stay kind of close, but it was just far enough away. And I had a lot of fun. I joined a fraternity. We did a lot of group stuff. You see, I'm at the bottom of the pyramid, far left. And then we did this thing called rope pull, which was like taken way too seriously. It's really just tug of war. That's me as an anchor, my like sophomore to senior year. That's us trying to pull. That was when I was a freshman. And then, oh yeah, so we used to like tie the rope to ourselves. It was really intense for no reason. I also did track throughout college. I did track my senior year in high school, and I wanted to do something more, so I joined the track team. And I did all the throws. This is, on the right side is weight throw. That's indoor. On the left, that's me and my team, the throws team. And that's actually at Icon Stadium on Randall's Island in New York City, so that was pretty cool. And then when I graduated, I stayed to do my master's in biochemistry, and my coach asked me, my throws coach left, and the head coach asked if I would coach. I was like, dude, I don't have time. I'm trying to do a master's and working 2 jobs. He's like, I'll pay you more. I was like, okay. So I got to travel with everybody, and it was a lot of fun because I knew most of these people, but the joke was always that all the guys were like these huge guys that are always in the way, and the girls would always get mad at us. And so they surprised me. The girl right behind my right shoulder, Emmeline, she made these shirts called the Large Men's Club and put a picture of me on the back. And so in our last meet, my last time as a coach, she surprised all of us with these. So that was nice. I went to Loyola for med school. This is our powder puff M1 versus M2 team. I'm in the back. While I was in Chicago, I had met some of my best friends in medical school, but I also did a lot with, I made a lot of friends outside. So I did a lot of like, this is flag football. We did a beer kickball league, which was really fun. This is just a holiday party with my non-med school friends. And then this is my graduation. My roommates and my friends wanted to do a graduation shoot, and so all denim. And then this was our house. And I matched here. And believe it or not, I did graduate. It's my brother and my sister. And I did have a mullet there. It was smaller than what I'd had during residency. But the thank yous, I don't have much time, but everybody at the U, there's plenty of people I'm missing, but I can't imagine how I would have made it this far without you guys. I think a lot of you have seen me struggle as an intern and hopefully got better by the time I'm a chief. I want to special thank you to Dr. Croman and Dr. Leslie for my time in the lab, and then more specifically, Dr. Graham. She's here. She, for those of you who don't know, she leads PCRC and is easily one of the best mentors and researchers I've ever met. She works harder than I'd say 90% of the clinicians I work with. So she's fantastic. And if you want to work in a lab, she'd be an awesome mentor. Everybody at Methodist and then at Regions, of course, spent a lot of time there. This is my shout out to my original class. I had so much fun with everybody. And then, as Julia said, COVID made things hard, but we tried our best to still have fun and support each other through it. And I wouldn't leave you without some mullet pictures. Second year. I know Dr. Meyer loves these. And now my current chief class, these pictures are, like Julia said, we have multiple pictures of all of us together, which is hard to believe, but I think being able to talk to you guys, whether it's cases or just vent, it's honestly really, really nice to be able to say something and not get in trouble for it. So, I want to shout out my pets. This is my cat, Kitty. I did name her that. My dog, Jasmine. And they do at times try to almost hang out, but like not quite. And then last but not least, this is my fiance. Many of you know. This is Diana on the left next to me. This is actually us at Coachella. She's been with me literally almost my entire residency. And she moved here for me. This is us at the state fair. This is her giving a great post Timberwolves game interview. And she's always down to go on any trip, adventure. This is us in Badlands, or in the Black Hills. And then this was us in Taiwan. And she's even willing to help me live my dream of being Guy Fieri. So can't say I love her more. As many of you know, oh yes, she's also beautiful, bald, and with a mustache. I told her I was putting the sentence. Many of you know I got engaged this year, so this was at the end of January in Japan. That's Mount Fuji in the background. I won't leave you waiting. She did say yes. So. And then this is us ringing the lover's bell at the end. So we walked by it, and our friends who were with us were looking at it. I'm like, I can't ring that yet. And so after we did, we were able to do it together. So obviously next year, go to Stanford for MIS for a year. Super excited. I want to try something else outside of the Midwest. And I love this. This is not what you should do. That's all I have. So don't do that.
What a very interesting talk. And you're just a pleasure to work with always. I love operating with you. I love hanging out with you. Thanks for being awesome. I have lots of questions I'll ask you offline, but I think my one that I'd like you to comment on. So, one size fits all, very near and dear to my heart. I'm 5 feet tall and have a glove size. Um, and I operate a lot in the pelvis, and I'm usually like this. And so my question is, I remember vividly during my 4th year of residency, I was doing lap chole, and I was like this, and I asked for the screen to come down. And the surgeon that I was with said, "Stop being a princess. It's fine for me." And so I'm wondering if you could comment on ways that we could tweak that culture a little bit. You commented a bit, but it's kind of a big topic, but I'm curious if you have any thoughts.
Yeah, I think at least earlier in training, I think it's hard to find your voice. And I do think now we facilitate advocating for yourself and speaking up more. But I really think even when you do, I've had those situations where I finally like speak up and I'm still, it doesn't matter. And those are tough situations. I think what is important, it has to kind of come from the top down. So on a higher level, administrative level, it has to start, the change has to start there and it has to trickle down. And part of that is also, even in the moment, you might not be able to do anything or make those changes, but it is really important to speak to someone about how some of these things are occurring, some of these behaviors are happening, because that's the only way you're going to actually change something. Same as you, I work with surgeons who are much shorter than me. And honestly, I've seen a large difference from when I was earlier in training to now, and people being much more accommodating. And half the time, I don't even have to say anything. They'll just have the step ready. But I remember it was not like that. So I do think on some levels it is changing. But I think advocating for yourself, but that also means sometimes bringing it up at a higher level and not just letting it go. So.
Dave, thanks for that talk. It was really interesting. I was excited for it. One comment and one question. A comment being also thank you for being an advocate on behalf of the female residents. As the only male in our graduating class, I think you do a really good job of noticing things that are happening around you and speaking up. Ergonomics being an example of that. I'm curious, when you were looking up literature, if there's anything out there about different staplers. You mentioned the staplers, but now with a lot of them being electric, if that has any, if there's any notice change in using those versus the mechanical ones.
There's one study I looked at that it wasn't really directly comparing them, but it did talk about how the electric staplers have made it easier. However, they also commented that the clamping itself can be quite challenging, and that's even like for me. Maybe that means there's too much tissue in it, but it can be hard to actually close those laparoscopic staplers. So even if the pumping action for the manual ones is better, there's still the overcoming the initial clamp, and I think that's still kind of an issue.
Did you come across anything other than using steps for operating with people of like very different heights and body types? Because using a step is also not ergonomic. It leads you to that static motion where you can't move.
Yeah, so part of it is like actual platforms, like not just steps, a whole platform that kind of takes up the whole side. Some places, there's some of those out there. I don't know how mainstream those are and how many people are using them, but in theory it seems better because I've also like me on a step in the lap pulley. You're on a step, but now your foot pedal, you have to put on another step, and then you're kind of balancing. So, but that is one thing that has been suggested. I don't know how much about it though. Actually, like a real platform, not just a step, which I do think would be helpful.
two quick comments. One, love. Your dog. We had these NASA task analysts that we put together an abstract, very realistic active shooter simulation over the old simulation center, and it was extremely realistic to the point where Dr. Chipman said, "Oh, this is way too stressful for the residents, but maybe the students could try it." And we had for the last year we've been working on a vest that the surgeon would wear with there are about 5 biomedical engineers, and I was disappointed to see it's already done. Of course, their price point was going to be about $100, and it was for students that would 4 little Arduino accelerometers and a vibrational beeper that would alert you to changing your posture, slouching. And it's coming out in 2 weeks, and I'm hoping our students will be willing to try it out. So everybody's interested, and I think it's a terrific talk.
Like I said, that one, the upright go-to, that's available, but it's only one sensor on your back, so it can tell you, if you're flexing too much, you're bent over too much, but it doesn't sense, your neck, for example, if you're extending or flexing your neck too much. So I think there's still room for other wearables that can be beneficial. So. Ted.
I'm just curious, thinking about the lower extremity harnesses. I feel like those would make you increasingly static, like exceedingly static. Or are they, if they're designed in a way that you can move around a lot? I feel like they're going to be rigid and you're kind of sitting on them all.
They're actually, not that I'm speaking from experience, but they're supposed to be very lightweight, and they offset a lot of the force and the pressure. So it's kind of like twofold. If it's making you more static, the impact of you standing still is probably lessened by the force it's taking on itself. At the same time, it's mainly like springs mechanisms, so they are trying to kind of oppose force. So in some ways, it's almost making you move. That's more anecdotal, but that was the only device. Most of the space is upper extremity exoskeletons. There's not. I know there's more commercially available things for. You've probably seen on ads and stuff, but in the surgical space, it's one of the only few ones. Hey, Alex.
I have a quick question. Does this mean that when you're attending, you would not let a med student retract something for 4 hours?
If you were my med student, I would. I'll be nicer to them.